Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling something called Kawasaki's disease. Now, before we get started, as always, let's jump into our practice question. Tuck that right answer away for the end of the episode where we will go over it together. All right, the nurse is developing a plan of care for a client diagnosed with Kawasaki disease. Which of the following should the nurse include in the client's plan of care? And yes, this is select all that apply. Should we include A, initiating contact precautions, B, obtaining a 12-lead electrocardiogram, C, offering soft foods and liquids, D, implementing fluid restriction, or E, administering aspirin as prescribed. So let's start out with what exactly Kawasaki's disease is. It is a pediatric condition, and it's one of those that can crop up on your exams, on your NCLEX, because it can have lifelong cardiac consequences. So we really don't want to miss it. Now, at its core, Kawasaki's is a systemic vasculitis. So systemic, it's all throughout the body. Vascular, the veins, itis, inflamed. So all throughout the body, we have inflammation in our blood vessels. Okay, that's it. That's basically the whole episode. But no, let's think about what actually happens when those blood vessels get inflamed. They swell, they get angry, that changes blood flow and then damages the tissues that those vessels are supposed to supply. All right, so Kawasaki's systemic vasculitis, our blood vessels get angry and swell up. Now, the biggest vessels we worry about in Kawasaki's are coronary arteries. Those are the pipes that supply blood to the muscle of the heart itself. And if the coronary arteries get inflamed, they can weaken, balloon out, and form what we call an aneurysm. That's the big, scary long-term complication. We do not want kids to develop coronary artery aneurysms. That can end up leading to myocardial infarctions, MIs, even in childhood. So even though we're going to get to the signs here in a second, Kawasaki might just start with like a little rash, a fever. Real danger lies in the heart, and that's why we talk about it. Okay, so what is this actually going to look like in practice? Usually, you're going to see a pediatric client come in under the age of 5. It is actually more common in boys, not to say girls can't get it, and often they look pretty sick. They've got high fevers that lasted 5+ days. They have conjunctivitis, actually red eyes, but no pus, and it is going to be bilateral. So both eyes are red. They're not goopy with pus, but they're both red. Bilateral, non-purulent conjunctivitis. All right, now on the mouth, we get lips that are red, cracked, and bleeding. We get the strawberry tongue, red, inflamed tongue, and that can even make it really painful for them to eat and drink. On the skin, we see a polymorphous rash, which just means that the rash can look different from kid to kid, but usually it is red and widespread. It might also present with some peeling, some desquamation on their hands and feet. So you should be picking up on a theme here. We have a lot of redness, red eyes, red lips, red tongue, red rash on the skin. You're getting the vibe? We're inflamed. All of our blood vessels are inflamed. And the other thing that gets inflamed is the lymph nodes. So often it's the cervical lymph nodes where we have that lymphadenopathy, that big swollen lymph node. Okay, you put all these things together, fever plus the rash, the conjunctivitis, the tongue, the swollen nodes, and you are thinking Kawasaki's. So big picture, Kawasaki's equals systemic vasculitis. Blood vessels get super inflamed. In kids, the big thing we're scared about is the risk of those coronary artery aneurysms. So we need to recognize all of these signs and treat proactively. So I'm going to tell you a story of actually the one and only time I have seen Kawasaki's. It is not incredibly common, but it definitely stuck out. So we'll look at how it presented and wrap up with treatment. So for me, this was when I worked in a pediatric unit just on the peds floor. Usually these cases aren't going to need to go to the ICU or anything. And this was, I think he was three, maybe going on four, little boy. His parents had brought him into the pediatrician for like a week of fevers, and then he had been transferred over to the hospital when the pediatrician saw the signs and knew he needed to be admitted. So the big red flag first, high fever over a week. So they had been giving him alternating acetaminophen and ibuprofen and would help for a few hours, but the fever would rebound. So responsive to antipyretics, but the source of the fever unknown. It's always coming back. Then he had the classic symptoms of bilateral non-purulent conjunctivitis. So both of his eyes are red, but they're not having pus come out of them. No goopiness, just red eyes. His lips are red, cracked. His tongue is bumpy, bright red. He is irritable. He doesn't really want to eat. He doesn't really want to drink, okay? So that is why they brought him in. The pediatrician did his assessment. He saw a nice red rash going down his trunk, down onto his fingers and toes, and decided he needed to be admitted. So this is the first time this has happened for this kiddo. He did not have a diagnosis of Kawasaki's prior to me taking care of him. So I get him, I'm doing his admission paperwork, I'm getting his history. He is a normal kiddo. He goes to preschool. He has an older brother who is in second grade. They live like out in the suburbs with a yard. They run around. They have dogs. He has a very average history. He's fully vaccinated. He's not on any long-term medications. He's never been in the hospital before. So first and foremost, when we see fever, we worry about infection. But with a fever going on for that long, this isn't just a simple like little rhinovirus or something. His fever is spiking and not able to be controlled. And then you put that together with all of the clinical signs we reviewed already. His eyes being red, his tongue being red, the lips being red, and all of that like mucosal and oral involvement is why he's not wanting to eat and drink. Okay, that is like a secondary symptom to the Kawasaki's disease. It doesn't make him not want to eat or drink, but that systemic vasculitis involving his oral mucosa makes it painful for him to eat or drink. So that's why he's getting dehydrated. That's why he's getting irritable. It kind of all cascades out from there. I was also able to appreciate the red rash and then palpate some pretty significant lymphadenopathy on his neck, particularly on the right side of his neck. I noticed was more swollen. It wasn't super tender. He would let me kind of feel around, but definitely swollen. So all of these things, hallmarks of Kawasaki, that systemic vasculitis. All right, so we are all on the same page with what is on the radar. How are we going to confirm this diagnosis and move forward into treatment and get this kiddo home? So first, we know the scariest thing is cardiac involvement. We need to go ahead and get an echocardiogram and an ECG, both which look at the heart and look for coronary artery changes and arrhythmias. Then we need to draw labs. We need to look for inflammatory markers, and we need to rule out infection because he's got this fever going on. So we need to make sure there's not anything else brewing under there that should be taken care of. Once the diagnosis is confirmed, we move forward to treatment. In the inpatient stage here, we are going to give something called IVIG. That stands for IV immunoglobulin. And that immunoglobulin is going to help calm down the immune system's overreaction. Because, at the root of this, the immune system is just freaking out and attacking all the blood vessels. We need it to cut that out. So IVIG, I'm not going to lie, one of my least favorite meds to administer. It is very time intensive, but you're going to hang that infusion and titrate every 15 minutes per your order. You need to watch this kiddo really, really closely for any reaction because that can occur with IVIG. Now, the other med we started, the one you're probably already thinking of, is aspirin. Okay, usually we totally avoid aspirin in kids because it can cause Ray's syndrome. And spoiler alert, that is going to be our next podcast episode. So circle back to hear about rash syndrome on the next one. But in Kawasaki's, it is the exception. That is the only time we give aspirin to kids. Why? Why do we do it? Because aspirin will reduce vessel inflammation. It stops the platelets from clumping inside our inflamed coronary arteries and can prevent those long-term coronary complications that we are so nervous about, okay? So Kawasaki's, the two meds we give, IVIG, aspirin. It is the only time we give aspirin in kids. What other nursing interventions can we do? It's all about support and safety, okay? With this mucosal involvement, we're going to offer soft foods and cool liquids since, eating and drinking is painful right now. It's going to go down, but we really want to encourage some fluids to combat the fever and keep him hydrated. Keep a close eye on his temp, heart rate, oxygen. Watch for any chest pain, shortness of breath, or new arrhythmias. He needs to be on a cardiac monitor as we get this under control. And luckily, with that IVIG, I would say by day 2 or so, we started to see a big change. That was when the fever broke, that vasculitis started to calm down. So all of the redness in the eyes, the mouth, the lips, the rash starts to gradually go down. That makes it easier for him to eat and drink, so he gets more hydrated, and everything starts to heal from there. Now, luckily, he did need to follow up outpatient with a cardiologist, and there was no evidence of any aneurysms on those coronary arteries. Not yet. So we caught this early enough to be proactive and hopefully prevent those from occurring. He's got to take aspirin for that. Aspirin, Kawasaki's disease. That's what I want you to take away. Because really, with Kawasaki's, it's about protecting the heart, okay? We have this systemic vasculitis, inflammation. We got to get that inflammation down so we don't have coronary complications, all right? We do that with aspirin, supportive care, and really close monitoring long-term. So that being said, let's circle it back to our practice question here. The nurse is developing a plan of care for a client diagnosed with Kawasaki disease. Which of the following should the nurse include in that plan of care? Select all that apply. So I'm going to go through these one at a time. I want you to call out yes or no. Should we put this in the plan of care for Kawasaki's? Should we put them on contact precautions? Is it contagious? Am I going to get Kawasaki's from touching someone with Kawasaki's? No. It is an immune disorder. It is not contagious. Only standard precautions are needed, not contact. A is wrong. B, should we get a 12-lead electrocardiogram, ECG? Absolutely, that should be a no-brainer. We're worried about the heart. We need to check out what is going on there. That is one of the diagnostic things we did. C, should we offer soft foods and liquids? Heck yeah, that mucosal involvement makes it painful to eat. We need to stay hydrated to get that fever down. Soft foods and liquids, yes, C is correct. What about D, implementing a fluid restriction? All right, testing strategy here. Opposites can't attract. C and D are opposites, offer liquids or fluid restriction. One of those is right. They cannot both be right because they contradict each other. So C is right, offer the liquids. That's going to help bring the fever down. D is wrong. Don't implement a fluid restriction. And lastly, E, administer the aspirin as prescribed. Yay or nay? You know it. Yes, Kawasaki's, we give aspirin. If there is one thing you take away from this episode, please let it be that we almost never give aspirin in kids because we're worried about rash syndrome. The one exception is Kawasaki's. Kawasaki's equals systemic vasculitis. All our blood vessels are angry and we need to calm them down, protect the heart. We do that with aspirin. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.